Thanks very much, Annette. And, the confession I have to start with is that we aren't doing terribly well in South Africa. So I am going to include same day with rapid ARV provision, because I think with the burden of disease, we're trying to focus on rapid, and there isn't that much happening on same day, but I am going to just give some of the country perspectives and some of our own work around this. Of course, just to remind you all that we're a country of 59 million, but we have almost 7 million people living with HIV, a lot of TB, still a lot of morbidity and mortality because of TB and HIV, and still a lot of infections. So I think the country is grappling with many balls in the air. I feel like there's a lot of focus at the moment on differentiated models of care to decongest our clinics and to really kind of move patients around that are stable. And so same day, frankly, hasn't been in the forefront, but I'm inspired by Dr. Nitya, and I think, we need to be giving this much more thought as we think about how to really improve the second 90. So I do want to point out that at the moment we have it's about 3.8 million actually people on antiretrovirals. We do 35 million HIV tests a year. About 60% of people know their HIV status. You can see how many viral loads we do. A lot of gene expert testing, and a lot of also emphasis on prevention. But 70% of the South African population use public hospitals and clinics, which are hugely oversubscribed, overcrowded. They have a very low ratio of doctors, so the whole of our service provision is actually nurse-driven. And much of our testing is done outside of facilities by lay healthcare workers. So we certainly have done the task shifting piece, which I think is important, but there is a disconnect between testing happening outside and treatment happening largely within facilities. So you start to struggle with that linkage piece, which I think is really important. We have done extraordinarily well, I think, on the testing side. So we're really on track to reach our 2020 targets. We do have to focus on specific populations such as men and older adults, as well as adolescents, as I pointed out yesterday afternoon. But there is, I think, extraordinary work done on the first 90. So this is our cascade as of speaking with Jürgen Pillay just a couple of weeks ago. And pretty much like you showed, Dr. Nitya, our second 90 is our problem. So it is an area where we have to do more work. So this is the South African treatment cascade for adults, and then more recently bringing us up to date. So South Africa, you see there, the second 90 our problem, and then my province, the Western Cape, even though we have really sort of run ahead in terms of treatment provision, MTCT provision, we still have a long way to go in terms of the second 90. So Nitya already pointed out who feels about this, the 7-day focus, but also with provision for same-day ART, remembering that it is important that we always give people that choice. So I think it is within that context of precision public health that we do still reserve the right to understand that some people may not be ready to start. So we do have to come with that, encouraging thought process, but also allow people to make their own decisions. This is the South African guidance on this. As of the 1st of September, we have a treat-all policy. Start as soon as the patient is ready, within 2 weeks, my government says. Prioritize those with low C4s. Pregnant women, we are trying to really reduce that time, and same-day ART is very much on the cards for pregnant and breastfeeding women, and I think this is where a lot of attention is going. And of course, fast-track those with very advanced disease. The Clinician Society, which represents a lot of the treaters in the country, always have their own guidelines. And you can see here that They have in their guidelines, and I freely recommend you go and read them. They're published, and often have a very much a pragmatic, on-the-ground approach. They certainly are encouraging people to think about rapid. They do give a bunch of medical reasons to defer initiation of antiretroviral treatment. So again, thinking of cryptococcal meningitis, TB meningitis, and of where we're concerned that there may be TB. And I've already pointed out how much TB there is in our country, so it's a very real concern. What are some of the reasons you might want to defer? So the caveats to same-day start is the patient must be motivated. This is not an adherence support shortcut. So in other words, I don't feel like doing all the adherence support, so I'm just going to start treatment. That needs to follow. So this is very important to recognize. That people should be contactable, so that if you do your bloods on the day, if there is renal dysfunction, that you can get the person back. We do recommend a serum or plasma creatinine antigen, and symptom screening for TB and cryptococcal meningitis before initiation of treatment is important. So you can, I'm sure these slides will be available and you can look at the data. So I do want to say that we are starting to see some evidence come through on universal test and treat at least, and an impetus to try and reduce the time to treatment. But I want to also emphasize that this is not without thinking about combination intervention. And so you see in this modeling study from KwaZulu, UTT is there, definitely brings the epidemic more under control, but more important also to think about other prevention. Here is a treatment as prevention strategy. It was published some time ago now, shown in Durban, which disappointingly did not show any benefit of universal test and treat and more attempt to more rapidly start people on treatment. This is the ANRS study, and there was no significant difference in HIV incidence between the control group and the immediate or rapid initiation of antiretrovirals in all. And it is thought that probably this is because of the long time that people took to start the antiretrovirals. So I do want to make this point, that we may undermine these treatment as prevention programs if we don't rapidly start people on treatment. And so, you know, to echo Nitty, I think there is really more and more evidence starting to come through that it is something for us all to be thinking about. We did a small study some time ago now, 2011, looking at rapid initiation, same-day initiation of ART in pregnant women. We did it from our mobile. We gave them treatment on the same day, and it was striking. Almost every single woman said, I will start my ARVs today. And the extraordinary thing was that this was the first time we pushed PMT-CT, mother-to-child transmission rate, under 1%. So definitely the benefit in pregnant women is, you know, I think, and this for us is an emergency, if you like, exactly what we need to do. And the added advantage here is a woman really feels compelled to do the right thing for her unborn child. So but importantly, we also found that it was safe and very acceptable. We went on to try and encourage people to go from our mobile testing to clinics as quickly as possible. And in fact, what we decided we would do is give a conditional cash transfer as a way to try and encourage people. Sadly, we saw no significant difference between those who were incentivized and those who were non-incentivized, and still only 67% linked to care. Now, the question here is, should we have had a third arm where we could have given antiretrovirals at the mobile? That would have been different. And this, you know, I think is the experiment we have not done. We've done it in pregnant women. We've not done it in the generalized HIV positive community. And I do think that this is something we need to think about. But what are some of the reasons people link to care? Well, they felt that the intentions to disclose helped, treatment readiness helped. The things that were negative in terms of linkage to care was that I feel fine. I don't feel like I need to get treatment at the moment. Alcohol played a role there, and internalized stigma. So we still battle in my country with 7 million people infected. We still have a huge amount of internalized stigma and perceived stigma. Art initiation, again, treatment readiness played a role, but alcohol was negative, and again, stigma a real factor. Additional barriers were people were worried about ARV side effects. Some people just denied that the tests, they were rapid tests, we used 2 rapids, they were just not happy to believe they actually had HIV, and many worried about lack of money for transport, money for food. So other priorities, a huge factor. Factors motivating treatment uptake included awareness of a positive art effect, so I do realize this is good for my health. Seemed to help a lot if there was personal contact. So I loved Matt Avery's talk this morning, but I wonder about this thing of taking the person out of the equation when there's a one-to-one discussion to be had. Seemed to be very important. Recognizing I need to be alive for my children and my family, and maintaining health to avoid involuntary disclosure was an interesting other one. We have tried PrEP uptake in our mobile, so PrEP, same-day PrEP in the mobile, and you can see a disappointing 47% retention. Now, these are in adolescents, so I do think the adolescent group needs special focus again, and I think, Nitya, this is one area where we do need to do some work. So I just threw that in as a cautionary sort of idea, take-home message. The RAPID trial is the randomized control trial that I think a lot of people quote, now published. You can go and read about it. Sydney Rosen wrote it up. It was done in Johannesburg, and you see this increase in uptake of art and viral suppression in the people who were given same-day art. So I think this kind of, is certainly for our setting an impetus to move in that direction. It has been tried in sex worker populations, so thinking of KEPOPs, this study's just been published. I'm not going to give you the detail, but I direct you to go and read in PLOS Medicine. Robin Ekel has, this is a dual cascade approach for sex workers. Those who were negative were given PrEP, those who were positive were offered rapid treatment, not same day, but rapid treatment, and you can see the cascades there, and go and read about what some of the difficulties were. Again, retention being a bit of a problem, although retention in the ARV side was better than the PrEP side. We will be seeing more data coming out, certainly in terms of universal test and treat trials. In sub-Saharan Africa, there are 5 underway. I'll point you to 3 of 5 are doing same-day art. So it's the BCPP study, which is in Botswana, the Max Art study in Swaziland, and Search, of course, in Uganda and Kenya. So go and read about those studies to understand a little bit more. They're outside of South Africa, but, it's sub-Saharan region. Pop Art is not doing same-day art, but they are trying very hard to do via home-based testing and home-based lay counselor intervention to try and get people more rapidly into treatment. And I'm, again, not going to give you all the details, but you can see the rapid initiation procedures there on the right in the intervention arm. Again, in PLOS Medicine, this has been published, and you can read the details. But I'll move to this slide in the interests of time. In fact, this slide, in the interests of time, to show that still it is taking a long time for people to get into treatment. And so both linkage to care and art initiation. And so I think this may well again undermine the treatment as prevention component of this, because it's just taking people a long time to get into treatment. So there's real world, a lot of human resource being thrown at this. These chips, these lay public people are going into people's homes in a very systematic way. So we're getting more people in tested, but the linkage to care really. So again, could they have in a bag the first dose a little bit like Diane Havler is doing in the SEARCH trial. And here is the SEARCH trial. I know you heard it presented last year at the symposium, and it really is a sort of a beacon for what could be done and how this can really move us towards the 1990. So this was shown at Durban 2016, how after 2 years, and I know Diane's scrambling to get this written up now, and I'm looking forward to reading her publication when it comes out. I'll, in the interest of time, move on to go on to this one then. So how do we go about even thinking about same-day art? Well, you know, Nitya is right. We do need a history. We do need a clinical exam, particularly in my region where we are worried about OIs that have a risk of iris. CD4 is still recommended just to help you think about those who have advanced HIV. People who have no clinical signs and symptoms of TB, and those in whom cryptococcal antigen is negative may initiate ART on the same day. For people whose CD4 counts are under 100 and where cryptococcal antigen testing results are not available, you may want to think about giving fluconazole prophylaxis until you get the CRAG back. And of course, we are guided by the WHO recommendations on the timing of ART in the presence of TB. So I will leave these slides because I know they will come up for you, but just to say there is very clear recommendations about when we start ART in people with tuberculosis. And again, I ask you to caution particularly those people who with TB meningitis, because we do need to be careful about the iris situation there. And then, of course, when to start in people who have cryptococcal meningitis. So again, those details are available both in the South African clinicians' guidelines, but also, of course, in the WHO. So I encourage you to go and read that there. So I'll stop really just to say that, I think this is a stretch goal. I think it's aspirational. I really do encourage us all to be thinking about same-day art, because I think some of that linkage, which means I've got to go from this place to this other place, does create that leak in our cascade. And I think it's only when we start to try same-day treatment that we'll be able to figure out who's going to benefit most from this and where we perhaps want to hold back and defer. In the rapid in pregnancy trial that we did, we called RAP-ART, it was very interesting. Most often it was the clinician who deferred the patient. So there was anxiety on the part of the clinician. And in every case where we deferred, there was no need when we look back. So we also have to overcome our own anxieties, I think, as Nitya suggested. I do want to just show you this slide because a number of people have come up to me here to say, I've tried to register, but things are a bit odd. Apparently, there are some fake websites, much as there is fake news at the moment. So I do want to just use this opportunity, if I may, to say this is what the website should look like when you go and register. And please try and do so before the 15th of February. And then I want to thank my very good friend, Graham Mankey's in South Africa, and of course, Jürgen, who supplied some slides for today. Brendan, who's done all the work on Eiling. Thanks so much.
Thank you.